Chairman and my friends. At first, I want to thank the organizing committee for the opportunity to talk about the hydatid cysts. Actually, this is my favorite topic. I'm working on this topic for more than 20 years. And I want to share my hospital, the picture of my hospital. I'm also a liver transplant surgeon, and we do more than 200 liver transplantations per year. This is university, hospital, and this building is the Liver Transplant Institute. At the beginning of my surgical career, at that time, we are trying to do radical surgeries for the hydatid liver cyst, but at the time, most of the cases are treated by conservative surgery. But as a young surgeon, we want to do more radical surgeries in order to prevent the recurrences and the biliary complications. But now we are doing major liver resections every day, but when I compare to the past, we are too far away to do a radical surgery for hydatid liver cyst, and we turn back to the conservative surgery for the hydatid liver cyst because maybe we learned to figure out the biliary complications and recurrences by conservative surgery. Is it worth to talk about hydatid liver cysts now? Yes, this is the European African HPB Association scope, the area, and most of the countries around the Mediterranean Sea is endemic for hydatid liver cysts. And most of the surgeons, like Turkey, like in the floor, lots of the surgeons are very familiar to treat the surgical hydatid liver cysts by surgery. And also, I think in the Western Europe, surgeons are meet to hydatid liver cysts because of the immigrations from the Middle East, Eastern Europe, and from Northern Africa. And the biliary complication is the most frequent complication of hydatid liver cysts. In the early postoperative period, it's the most important one. In the late period, it's the recurrence. Because of the theme of this meeting is the biliary fistula and biliary complications, so I'll focus on the biliary problems of hydatid liver cysts. What's the importance of this complication? It causes a prolonged biliary fistula. Most of the patients can carry out the drain on them for sometimes for weeks. Also, it can cause cavity infections, and sometimes it requires an interventional endoscopic procedures like ERCP, nasobiliary drainage, endoscopic stenting, or ECT, and it causes a prolonged hospital stay, and also it increases the health expenditure. And what's the clinical finding of biliary problems, biliary cystobiliary communications? Most of them, 95% of the hydatid cysts in hydatid cyst cystobiliary communications are occult, not evident. Only 5% of hydatid liver cysts admit to the hospital with obstructive jaundice. And after a drainage of the cyst by surgery or by sometimes percutaneous drainage, it becomes evident. And when you check the incidence of cystobiliary communication, it has very large range, the incidence, because of it depends on the determination method of the cystobiliary communication. If you only report the postoperative persistent biliary fistula, you can say that the cystobiliary communication rate is only less than 5 or 8%. But if you examine the biliary drain carefully in all patients and you follow the patients in a prospective manner, or you can do a biochemical analysis of the drain amount, the drain content, for example, biliary beans, then you can say that the incidence will increase to 3 or 4 folds. But if you do a provocation test, like a biliary leakage test, if you push a dye or saline into the intrahepatic bile tract to see the biliary orifices, then you can see that almost half of the patients in the cyst have a cystobiliary communication. Or you can examine the pericyst by microscopy, then you can say that almost all of the cases have a cystobiliary communication. What are the risk factors for the cystobiliary communication in hydatid liver cysts? In the literature, there are lots of studies on this. We examined also this topic, and we found that there is no relationship with the patient age, and also there is no difference between the primary cases and the recurrent cases. And also there was no difference between the right lobe hydatid cyst and the left lobe hydatid cyst. But that doesn't mean that the location is not important. In the next slide, I will talk about it. The location is important. Also, not the patient age, but the age of the cyst is important for the cystobiliary communication. As you know, the cyst becomes small and becomes larger. From young, it improves, it becomes mature, then it grows, the diameter increases, and it becomes from univesicular to multivesicular, and during that time, the incidence of cystobiliary communication increases. So I can say that not the patient age, but the age of the cyst is an important point for the cystobiliary communication. The right and the left lobe locations are not different, but cysts located near to the hepatic hilum has a more risk for cystobiliary communication. If we examine that for the segments of the liver, segment 1, 3, 4B, and 5 always had a more than 50% risk for cystobiliary communication if you do a routine cystobiliary test, bile leakage test. In order to prevent the cystobiliary biliary complications, is it reasonable to separate the cysts as high or low risks? According to our findings, because the low risk group still has a high cystobiliary complication risk, we cannot ignore this high risk in this group. So we can say that in our practice, we have to do a test for prevention, a routine preventive procedure. It should not be separated the patients. I mean, if we divide the patients in high risk and a low risk, and we can do for example, an MRCP or some intraoperative cholangiography for the high-risk group, and we can omit these preventive procedures or diagnostic procedures in the low-risk group. It will not work because the risk is still high for the low-risk group. Can radical surgery can be a solution for this problem? We tried it in the past. But as you know, it's not suitable for all cysts because if the cyst size is more than the diameter 10 centimeter, almost 1/3 of the cyst has a close relationship or adhesion to the major vascularities such as hepatic veins or IVC. Also, for sparing the healthy parenchyma, you have to do irregular resections, pericystectomies, and that may result to a very wide cut liver surfaces. And during this surgery, there is always a risk of increased bleeding, and it's very pity for a benign disease. It's a parasitic disease. There is also some risks. This is a real patient. This is a 12-year-old girl. The surgeon tried to plan a surgery for 2 bilobar cysts. The surgeon wants to radical surgery for the left side, and in the middle one, he tries to conservative surgery, but in the anatomy of this patient, the right hepatic vein is occluded by the large central cysts. The middle hepatic vein is open, and the left hepatic vein is open. And surgeons do surgery like this. He do a left hepatectomy, left lateral segment resection, and the suture to the cavity by capitonage or introflexion, and it occludes all the middle hepatic vein and left hepatic vein, and this patient referred us for acute Budd-Chiari syndrome after hydatid liver surgery. And in our 2000 liver transplant experience, this is the unique case for hydatid liver disease that required a liver transplantation. According to us, which patients are the candidate for the radical resections? Very peripheral, for the peripheral lesions, we want to do a radical surgery, and we still do conservative surgery because it's suitable for almost all cysts, and it's more safe and more simple. Which routine method can be used for the prevention of biliary complications during conservative hydatid liver surgery? For example, decreasing the intrabiliary pressure can be a solution. Placement of a prophylactic T-tube or prophylactic preoperative ERCP or cystic duct drainage. These are working. They are decreasing the risk of biliary fistula. But the problem is in the different point. For example, you can obliterate the cavity in order to avoid the complications, but you can see here that by using the omentoplasty, the complication risk decreased from 12 to 4, but still it is high. The problem is not obliterating the cavity, or we cannot solve all the problems by decreasing the pressure of intrahepatic bile duct. The problem is the connection. So I think we have to focus on this connection, and this connection is the main problem. And obliteration of the cavity and also decreasing the bile duct pressure can be an adjuvant treatment. The main focus should be this. Are all cystobiliary communications are visible? Unfortunately, they are not. Because of the cyst structure, there are some leaves. You cannot see all the orifices. This is very usual to find out. During the surgery, there was no bile staining, and you put a drain, or the radiologist put a drain into the cavity, and 1 day later, there was a bad surprise that there are lots of drainage, the bile drainage they're coming from drain, because they are not, all of them not visible. So to try to then make it visible, we can do a provocation test through the common bile duct. With a 22 gauge vessel angiocat, we puncture the anterior part of the common bile duct. We do a Pringle maneuver and check the cystobiliary communication, and we suture them during surgery. And we do a cavity obliteration, usually, if it's possible, by omentoplasty. Does it work? Is this work? The test works? Yes, it works. This is the details. When you did not do any test, you can only see the 13 biliary orifices. When you do the test, it increases significantly. The biliary complication decreased significantly, drain removal time, and in the test group, we did not require any postoperative ERCP anymore. Transcystic access cannot be chance. Instead of puncturing the anterior part of the common bile duct, maybe cystic duct can be used. We tested, but it did not work because of the internal opening of the cystic duct. If it's too distal, near to the duodenum, it's not working. Is cholecystectomy always necessary? For the left-sided cysts, we cannot do any cholecystectomy. It's not to do cholecystectomy for the bile leakage test. Despite all of these preventive precautions, if a postoperative biliary fistula occurs, we wait for 10 days because in our experience, 2/3 of these biliary leakage stops spontaneously. It's self-limited, and during this period, the patients become better. The convalescent, we are waiting for the recovery of the patient. We do not hurry, and after 10 days, we go on for the ERCP. As a conclusion, during conservative identification of biliary orifices with routine bile leakage test and suturing the cystobiliary communications significantly reduced postoperative biliary complications. Thank you for your attention.